tonight. I'm Tammy Sparacino. Normally Joe would be with us, but Joe got called away to do some clinical work. So tonight I will also be joined by John Ingram shortly after we just get through some of the opening remarks and housekeeping. PerfWeb is sponsored by HET. We have our social media, Facebook, Twitter, LinkedIn, YouTube. Please like, follow, share us on YouTube. Please enable the notifications so that you're able to find out about our programs. Sometimes we do unscheduled ones. And if you could, please take the time to leave a comment. It really helps us in our ratings. We would like you to visit our websites. We have perfusioneducation.com. That is our library where we keep all of our PerfWeb and Journal Club programs. And then perfweb.us is where we have our schedule of upcoming events. Please feel free to contact us at contact@perfusioneducation.com. And when you see this number on the screen, our call-in number, you can feel free to call in and join in the discussion Beyond the Air Live. I'd like to also tell you about our new app. It's a critical care app that we have two versions of it. We have the critical care portion that is just really an IV drip calculator. A lot of nurses like to use that. Or you can go ahead and get the full app, which will include that, and it'll also have many other features, including your perfusion quick calcs. It's $2.99 for the full app that has all of the features, and it's available on the App Store or in Google Play. We also have our programs being converted to podcast, and you can find those on your favorite podcast providers such as Podbean, Apple Podcast, Google Podcast, Spotify, or anywhere else that you listen to podcasts. All right, well, we are just going to get right into it. I'd like to welcome John Ingram.
Good evening. Good evening, Tammy. How are you?
Hi, good. How are you today?
Sound good? Look good?
Yeah.
Everything good? Joe's actually having to earn his keep for a change, I guess, huh?
Yes, we're having to put Joe to work tonight, so it's just going to be you and I. All right, so if without further ado, I think we will put my slides up for our Journal Club 19 and go ahead and get started. Okay, the article that I selected to talk about today is actually a case review. And it was published in the journal Medicine in January 2020. The title of it is Heparin-Free Veno Venous Ecmo in Multiple Trauma Patients. It's by Dr. Lee and his colleagues. Well, there we go. Okay, so let me just tell you a little bit about this article. I'll read you some of the abstract. So this is a case report, and it's looking at a 17-year-old multiple trauma patient who was presented in the ER, went into respiratory failure, and they decided to initiate Ecmo. And we'll go ahead and just kind of get started here. Okay, the reason why this paper was published, obviously it's a case study, an interesting one at that. The problems that we're going to solve, we're just going to discuss how this patient presented and what they did to treat her. And we'll go ahead and get started with the case presentation for our hows and methods and procedures. So this is a 17-year-old female, 160 centimeters, 48 kilograms, BMI of 18.75. She was admitted through the ER for a motorcycle accident. She was drunk and had a confused mental state. She had multiple fractures, left femur, right pelvis, both mandibles, multiple right ribs, and a tooth. She had a severe right lung contusion, several scalp lacerations, and she had an injury severity score of 34, which I'm not real familiar with that scoring, but it was graded as severe. Okay. Initial vital signs, blood pressure 98/60, heart rate 118, respiratory rate 38, and with a 98% saturation on room air. Shortly after being admitted to the ER, she had a sudden drop in her saturations to 85%. She was intubated on PRVC, tidal volumes of 350, FiO2 40%, respiratory rate 14 with a PEEP of 7. She also had a right-sided chest tube inserted. Okay, the authors talk a little bit about Ecmo contraindications for respiratory failure, and since we talk about Ecmo so much, I thought it would be good to go ahead and just have a look at what they listed as contraindications. So they only had one absolute contraindication, and that was for severe irreversible respiratory failure. And then they had several relative contraindications. The prolonged use of high-pressure ventilation or high FiO2, limited vascular access, contraindications for using anticoagulation that would be necessary for Ecmo, the presence of disease or organ dysfunction such as irreversible brain injury or untreatable cancer, inability to receive blood products, high BMI greater than 45 is the parameter that they used, and then any major immunosuppression. There we go. Okay, and then they talked about that there is various Ecmo criteria for respiratory failure. Now these are typically used in ICUs, but these are the four that they listed for the parameters that they were looking at. So they had a PaO2, FiO2 PF ratio of less than 100, FiO2 of greater than 90% despite having optimal care for 6 hours or more, PF ratio of less than 80 with a PEEP 15 to 20, hypercapnia with high plateau pressures of greater than 30, and a pH of 7.15. The third criteria, PF ratio of less than 50 with FiO2 greater than 80% for greater than 3 hours, or a PF ratio less than 80 for 6 hours with a pH of less than 7.25 for 6 hours despite optimal ventilation. Okay, here's their VV Ecmo application for this patient. This patient had cardiac arrest due to severe acute respiratory failure, massive pulmonary edema during general anesthesia, despite returning to normal circulation, spontaneous circulation, after 45 minutes of CPR. Still, she had severe hypoxemia with PaO2 of 31, hypercapnia, PCO2 of 115, acidosis with a pH of 6.81. She had continuous large amounts of pink, frothy, watery secretions from the ET tube. VV Ecmo was initiated to prevent recurrence of cardiac arrest. Ecmo support, and this is, I thought was interesting, they used it as eCPR. Now we've talked about eCPR before, and normally that's a witness cardiac arrest, and traditionally it's going to be VA Ecmo, but because they were anticipating that she might have cardiac arrest again, they went ahead and put her on Ecmo, and they thought, they described it as an application of eCPR. Okay, here's just some of her labs, and if you'll look in the first column, that would be initially when they had anesthesia. The second column is after they started the operation, because they did have to take her to the operating room to start trying to repair the multiple fractures that she had. She had a great amount of bleeding. Then you can see the third columns once they started CPR, CPR after 20 minutes, when she had spontaneous return to normal circulation, and then after on ECMO. Okay, so the author's conclusions. Heparin-free VV ECMO can be used as a resuscitative therapy in multiple trauma patients with clinical respiratory failure accompanied by coagulopathy. Even in cases in which life-threatening hypoxemia and severe hypercapnia and acidosis last for greater than 1 hour during CPR for cardiac arrest, VV ECMO could be considered a potential life-saving treatment. I didn't really go into the detail of why they didn't want to use heparin, but it was because she was bleeding so much. She had major coagulopathies going on. They reported an ACT of over 500. She was put on the VV ECMO, maintained that support for 3 days, was able to be successfully decannulated, and then remained in the ICU for an additional week, and fully recovered with no apparent neurologic deficit. Okay, that's the article. So John, what do you think?
Wow, that's a great case, and it just goes to show you when you have youth on your side,
yes,
what can happen. And we actually use that that mindset a lot at our institution, and I don't mean for people this young, but even people, you know, in their 30s and 40s and 50s, and we consider age to be a big asset, even in those decade groups, you know. And there is, you can see huge. They just have something big on their side when they have, you know, a younger age group. They just are able to overcome so many things that are thrown at them that as you get older and older, you seem to not be able to, and you seem to fall into more complications as opposed to recovering from the problems you do have. So that's a remarkable testimony to that, and we definitely subscribe to that. I was wondering if you could go back to some of your very early slides. I wanted to see if we could follow this case through step by step closer, because it was a very good way you outlined everything, and I wanted to see what transpired and what she fell into as far as their category for doing it and not doing it. I mean, certainly at her age, there wasn't too much that was going to eliminate them from trying that. Hardly at all, in fact.
Okay, let me pull the slides up again real quick, David, and I'm going to...
First or second slides where you start to talk about, let's see, pretty much near the beginning. I think it was the second slide.
This one?
Okay, so she comes in, right? So she's a motorcycle accident victim, 17. She's been drinking and everything, and so she got into a motorcycle accident, or she was riding on the back, not sure which.
Yeah, it didn't say.
I'm not familiar with this injury severity score. I don't work in trauma, but I'm pretty sure that in the trauma world, as they say there, that's a pretty severe, multiple trauma injuries and stuff, and multiple bone fractures and breaks. So we kind of get that. And then and then the next slide, I think you talked about her initial blood gases when she came in are actually surprisingly good, right? She actually came in, you can tell that her heart rate's up, of course, because she's lost some blood, and of course she has adrenaline going, and then she's breathing very, very rapidly, and that's because, she's got one lung that's probably down or mostly down.
Yeah.
But she's actually supporting herself at the moment. She comes into the ER and she has a 98%, arterial saturation on room air, which is pretty doggone good. So, but she's 5 minutes into the ER, and that's when she really starts to crash. So one thing I would point out is that right there it shows you that the EMT people and the rescue people got her there, with a little bit of time to spare, as opposed to bringing her in when she was already crashing. So 5 minutes into the ER, I guess she really starts to go downhill. Probably had too much blood loss.
Yeah, too much blood loss.
And so they have her on a vent, but you notice they only have the FiO2 at 40%, which I find kind of interesting. I wonder why they wouldn't have gone straight to 100. Maybe because her sat was so good, they didn't need to.
Yeah,
What are your
maybe
thoughts
so.
about that?
And then, of course, I didn't detail everything in here, but then, they talk about that immediately after she was vented, that they had to go ahead and give her heavy fluid resuscitation blood
Yeah.
transfusion. She was given 2 liters of crystalloid, 5 units of PRBCs for just being 1 hour in the ER. Then her blood pressure from there suddenly dropped. So she had a very low mean pressure. She had 66 over 39. Her heart rate continued to increase. It's up to 130. They decided to start giving her norepi. And then they got back.
She was actually in the ER for an hour, you're saying, before
Yes,
they
that's
could
what it says.
get her to the OR, probably, right?
Yeah, probably so. And I think they were just doing, active fluid resuscitation at this point. And I'm sure they expected her blood pressure to go ahead and come up, not drop. But it did indeed drop.
I wonder, where she was bleeding. It sounds like it might have been internal. So,
Yes.
they must have had a quick bedside chest X-ray,
Mm-hmm.
and they saw that the right side lung was down, and I guess they decided to put a chest tube in, right? And
Yes.
that's what it looks like there.
Yes.
But apparently they were able to kind of, oxygenation-wise, it felt like it was okay at 40%. Then it was all about fluid resuscitation. Okay, so I'd like to go on and to your next and see. So now I got a good idea kind of where what happened here a little bit.
Well, and then just to continue further just a little bit, since we're already kind of in some of the details, after they've given her the 2 liters of crystalloid, 5 units of PRBCs, her blood pressure is continuing to drop. They transfused her with another 5 liters of crystalloid, an additional 5 units of PRBCs, 10 units of FFP, and then she was evaluated with a CT for the brain, abdomen, pelvis, facial bones, and chest. The ER physicians decided that she should undergo a surgical procedure on her left femur fracture in both mandibles. So she must have been bleeding severely in those particular areas.
Well, that's also what I was wondering, is what did she actually go to surgery for? But, I'm not an orthopedic or a trauma expert, but I would wonder, if you have a large bone breaks like a femur, how much internal blood bleeding does that produce? I mean, that's in your bone marrow where you're manufacturing an awful lot of blood normally is in your bone marrow. When you break a large bone like that, I wonder what the implications are for blood loss, because it's not talking about a large artery that's been severed or anything. There may have been, they might not have known that at the time.
They don't note it if it is.
But it sure sounds like she's pouring out somewhere, because they are pouring it in. 5 liters of crystalloid, that's practically her whole blood volume. In fact, it is.
Yeah, for someone that small.
Kilograms, she was a little 98-pound 17-year-old girl, and she doesn't have a whole lot of blood. I don't think she has 5 liters, I can tell you that. So they're revamping or recycling her entire blood volume there, probably a couple times over there just in the ER.
Yeah, and then they say that 25 minutes after the start of surgery, her blood pressure drops from 130 over 100 to 78 over 40. She got high doses of norepi. Heart rate continued to increase. It's up to 151. Her saturations are 75%. Continued to get, this is where they really started noticing those frothy, watery secretions from the ET. They ventilated her manually, but her SATs were only 52%. So this is their decision time when they're trying to figure out what they're going to do. She gets sudden cardiac arrest. It took them 45 minutes, but then she came back. And then they were so afraid that she was going to have a cardiac arrest event again. That's when they decided to do the VV Ecmo.
Yeah, so stepping back just a little bit, you've seen this 100 times. We all have in perfusion and even other fields, is that the patient is bleeding internally, but the pressure of the tissues around that area and the skin are kind of acting as a compression. And as soon as you make an incision and release that pressure, now you bleed even worse, right? So you're at a catch-22. You need to get in there to repair some things so that you can start getting things under control. But the first thing happens is you take a major step backwards, because now you open up the floodgates for whatever's bleeding to just flow even more freely. It sounds like, that's sort of what happened here. So that's expected. I think that sort of makes sense. So then they got into a real volume situation in the OR. But with all that crystalloid, I know they were putting in blood as well. I'm sure at a trauma center like this, they had the rapid infuser devices going. But you lose your hemoglobin. You know what I mean? Your hemoglobin count as quickly as you can get blood in, but you're trying to put in coagulation factors, you're trying to put in albumin and crystalloid, you're diluting your hemoglobin, almost faster than you're able to give it. So your delivery of oxygen now is starting to go down, and it affects your heart, oxygenation, and of course your brain you worry about. So they had that struggle in the OR, but I guess they went ahead and did ECMO in the OR.
It sounds like they went ahead and did it in the OR. Let's see, I'm just looking at that table. Let me throw it up again. Let's see. So we can talk about a little more in detail. So it looks like even after she had returned to spontaneous circulation, her PCO2, it looks like it was really, obviously the O2's down, but the PCO2 was, 115. And even after they initiated ECMO, took it a minute to go ahead and come back down. It looks like they don't say how long. It just says immediately after ECMO initiation, down to 60 for the PCO2 and up to 60 for the O2. And then their discussion is just mainly talking about the new growing evidence suggesting that ECMO as a rescue therapy in trauma cases. And, really discussing that although it's highly invasive, that the application of it can be successful, and that you can be successful with heparin free when you have these patients that are have coagulopathies. She was, let's see, where do they talk about it? I think it's back here. Her activated clotting time was 510, and all other coagulation tests show extremely prolonged times. Looks like when her circulation came back spontaneously after the CPR, her PT was 27 and her INR was 2.57.
Yeah, and you have a dilutional coagulopathy going on. You have all that crystalloid you're trying to replace, blood products, and I mean, when you get to that one column there, CPR 20 minutes, and then the one after that, return of a spontaneous circulation, you look at the pH of 6.85, and most people consider 6.9 and below incompatible with life. Now, that doesn't mean you're instantly dead, but you're not going to stay there for very long. But again, being 17 and being probably a pretty healthy, she doesn't have, she's tiny and probably relatively fit. She's able to withstand, 20 or 30 minutes probably of a below 6.9 pH. So that's just a testament to youth. And also now I don't do trauma ECMO, Tammy. Sounds like maybe you don't either. No. And that is a subspecialty of ECMO altogether. People that do trauma and do trauma ECMO are really way out there on a limb. You've got a patient who's totally bleeding and is probably going to continue to bleed, and now you're going to put them on an ECMO circuit, right. And desperate times call for desperate measures. However, there is there is an absolute application for trauma ECMO, and there's absolute success that is and can be derived from trauma ECMO. But you really better have your wits about you. You better really know what you're doing, because you can't really afford to anticoagulate. You can see the patient. You said the ACT was 500. I mean, what more do you want to do to feel like your problem is not going to be clotting on ECMO. That's not going to be your problem. Your problem is going to be aggravating the present bleeding that's already overwhelming you. So you have to do it to keep her alive. The heart and the brain were gonna be so hypoxic that they were gonna die, and they probably had femoral access, is my thought too. They were operating on the femur, right? And they probably had a cut down right there, ready to go with a fem VV probably right there on one leg, and they probably were able to do it relatively quickly. And
it says right femoral vein. They were able to get a 19 French access cannula. and then a 21 French return cannula. So.
Yeah. So she went to a good center because they had it all ready to go. And so that was a testament too. So let's see where your slide are. I want to walk through this a little more and see how this turns out. But that's a pretty good slide because it tells you right there in the last column, you've blown the CO2 down from 115 to 60, and I'm sure the perfusionist cranked that sweep and really started reversing because you have a severe respiratory acidosis along with a metabolic acidosis. So you've got two things you're working on there. So yeah, okay, so I see what happened now. They're on ECMO.
And real quick, let me just interrupt you for 1 second, John. I'm sorry. I believe we have a caller.
Oh, great. Okay.
Yeah.
Hi.
Yeah, we have.
Oh, it's Joe.
Hi,
Joe's our caller.
It's
Joe, all right.
I'm your
You want
call.
to spin the wheel?
Hey, guys.
Are you trying to get us to spin the
So,
wheel? I don't know.
Yeah. So let me just throw this out if I can. Yeah, I'm in the traffic. I've got an hour and 30 minutes to get from here to there. So I'm in the Houston traffic. But very quickly, I think John brought up an excellent point. One, you've got youth on your side. The second thing is, I think that they recognized she was bleeding. It sounds to me like they just poured volume into her, which I think caused two problems. One, I think they fluid overloaded her heart. They put her over the Starling curve, and she went into failure, pulmonary edema, and that's why that happened. And I think that her coagulopathy is likely secondary to dilutional coagulopathy. They were pouring in crystalloid, they were pouring in red cells. They probably got way behind on platelets and factors, plasma, so cryo, so forth and so on, and then she started bleeding. I think that the fact that she was only on ECMO for 3 days, and I think that if you look at the algorithm for ECMO decision, that if they thought her cardiac dysfunction was secondary primarily to hypoxemia, then putting her on VV ECMO made the most sense.
Right.
So those are my thoughts so far, other than to compliment you guys that you're doing a fantastic job, and I'm actually listening to you in the car, in Houston traffic, and enjoying the show. So keep going on, and I'll talk to you later. Thanks, bye.
Thanks, Joe. Bye. Joe makes an excellent point about the dilutional coagulopathy. They don't mention that they run a TEG or anything like that that's going to give you a little bit of that information to try to figure out what's causing the coagulopathy. So it sounds like they just ran your standard PTT, PT, and INR, and I guess an ACT.
Yeah, and I think you don't need to be a cardiologist to realize that a 17-year-old young girl probably doesn't have a heart problem. You know what I mean? That if she is not being able to keep up her blood pressure, it's because she doesn't have volume, and that she's not oxygenating if she's hypercapnic and she's a low PO2. So yeah, they did VV. I suppose they could have done VA, but they did VV knowing that this young girl needs oxygenation. She's hypercapnic. She needs ventilation, and if we can get that turned around. But yeah, I was wondering too when you said that they started getting frothy suction out of the ET tube. Wow. I mean, usually you have to have left ventricular failure and right-sided good flow out of your right side ventricle and pour out of your left side and build up pulmonary edema. But her heart was working well, I'm sure. So they probably just had fluid going in so fast that it just sort of filled up the venous side and poured right into the lungs. It was probably almost like a flash pulmonary edema, I would think.
Yeah, I would think so. I mean, just looking at what they gave her, in the initial, looks like about an hour, was 7 liters of crystalloid, 10 RBCs, 10 FFPs. That's a lot for a tiny little person, no matter how much you're bleeding. That's a lot. Yeah.
I mean, I'm not faulting them. I think they were in a desperate situation.
I'm sure
with
they
a
were
young
just
girl
trying to
and her
keep
whole
her
life
blood
ahead of
pressure
her.
up.
So they were being aggressive, and you walk a fine line. The pressure's low. the patient's pouring out, and you need to get volume in. So it's not terribly difficult to overdo it, you know, and suddenly the surgeon gets control of the bleeding, is able to clamp a few things or what have you, and then all of a sudden the bleeding suddenly slows down a lot, but the anesthesiologist, and maybe the perfusionist too, by the way, with the cell saver or whatever they were doing, rapid infuser, are still pouring blood in, you know, so it wouldn't be that hard to do on a small VSA person like this. So
exactly.
what was the next segment there, Tammy? I wanted to see how it was.
Oh, okay. So we went to just the
Okay.
conclusions where, you know, this was their major conclusion, was just that VV ECMO can be used, you know, in a trauma environment for resuscitative therapy, and if they have coagulopathies, that you can do it without heparin. You know, they had a severe hypercapnia and acidosis for greater than an hour during the CPR, and this ECMO saved her. And she was discharged from the hospital, I want to say it was 33 days. Let's see. Hold on. 33 days of ICU care. Then she went, during that time, 3 additional surgeries. But she was discharged after a full 128 days of with her hospitalization and rehab therapy. So it was a success.
Yeah, it sure was. I mean, she probably will. She'll have some scars, and she's probably got a handful of steel pins and rods and what have you. But she may actually go on to live a full life. She didn't go into any organ failure. Again, you know, a testament to youth probably on that one. She was able to withstand the inflammatory response that the ECMO circuit was going to instill in her, and no really detrimental effects from that apparently. And as soon as they got the bleeding under control, you're telling me she was on ECMO for 3 days. So she was then able to support herself, you know, cardiopulmonary wise. The lungs relieved themselves of the pulmonary edema they were seeing in the OR, and her heart was beating fine. And after 3 days, they could come off ECMO. I mean, that's pretty good, because a lot of times you spend 1 day of ECMO just, you know, weaning the person and doing sleep trials and stuff. So
yeah,
pretty impressive, actually.
It is. I thought it was a really interesting case study, and it had a nice result, which always makes it even more fun to talk about, really. Let's talk about a little bit. You talked a lot about in our spring conference about you had a whole talk about anticoagulation and heparin-free ECMO. So I didn't really want to get into that part of our article because we've kind of already covered that. But I thought it'd be worth talking about just our inclusion, exclusion, and kind of the impact that COVID-19 has had on that for ECMO. So that's what we're going to spend a little bit of time talking about now. Okay, so I used as a guide, and we've touched on this a little bit before, but not in this much detail, I don't think. The ELSO guide that they put out in 2019, they had to put together some interim guidelines for how we're going to deal with this COVID-19 crisis and pandemic in relationship to ECMO support. So this is the I believe they called it the interim document, consensus document from international group of interdisciplinary ECMO providers. Okay, so this was published in a SIO in 2020. I'm sorry, I lost the month. It was right at the middle of 2020, I believe. And it was, let's see, so here, I sort of just skipped ahead. I didn't really read, go through all of the, why they're talking about, why they're going to have to manage all of these things. I just wanted to kind of get to the parts where they talk about inclusion and exclusion for ECMO. So if you look at this first slide, it talks about indications for VV ECMO. And they're speaking specifically about COVID-19, but I thought what they said was really interesting because now we've seen it play out a little bit. We've had a year of this already. And it says here that you should not deviate from the usual indications for per ELSO or any other existing guidelines. They still are recommending to follow those guidelines with these additional guidelines for COVID-19. They recommend against initiation of ECMO before maximizing traditional therapies for ARDS, in particular proning. And you know, we were seeing that quite a bit for a while. That was the thing. You proned them, and then if they didn't do well in proning, then you went to ECMO. But I don't know about you, John, but we're starting to see that maybe we're jumping ahead on that, because it seems like they're trying to get people on a little more quickly. They also talked about that you know, they don't really understand ARDS in relationship to COVID-19. It's still evolving. There's going to be a debate about atypical nature of ARDS in these particular patients, that the, you know, vent strategies should be, best vent strategies should be applied, that vent management before ECMO may be significant bearing on outcomes, and I think we're all seeing that, you know, how those patients are being managed, what kind of pressures, what kind of tidal volumes, how long are they being managed on the vent before, you know, people are making the decision to go ahead and switch over to ECMO support. And then they talk about that mobile ECMO is unavailable, considering referring patients. If mobile ECMO is unavailable, consider referring these patients to ECMO centers very early, so that you're getting them over there before their you know, PaO2 gets really too low and their FiO2 gets really high. And they're recommending that you know, anything below 100, you should probably go ahead and refer. And if the decision to transport is made too late, that these patients are definitely going to be too unstable to transport.
And that assumes that you have an ECMO center that is not already overwhelmed, that
Right.
will take the patient.
Right, and I'm going to get to that too. Just on the other side of this is talking a little bit about VA ECMO. So it talked just talking a little bit about that indications and patient selection for VA ECMO should not deviate the existing guidelines. That consider VA ECMO in selected patients with you know, refractory cardiogenic shock, persistent tissue hypoperfusion, systemic blood pressure less than 90, while receiving, of course, various supports. The need for hybrid configurations such as VVA you know, is relatively infrequent, but it should be considered for experienced centers with doing this for patients with ARDS that also are suspected to have acute stress or septic cardiomyopathy. Patients requiring VA ECMO support who incidentally test positive for COVID-19 but are not thought to be critically ill due to the virus should be considered for ECMO support in the usual fashion. All right.
Okay, yeah, go ahead.
All right, so here's just their conventional VV indications for ARDS for ECMO, and it just goes through kind of the decision chart here. I think it's similar to what has been put out before, but it's been modified, I believe, a little bit for COVID-19. You can see the first step. As soon as you have a PaO2 of less than 150, that you are strongly recommended to prone. Then from there, you know, recommending a paralysis and appropriate PEEPs, and considered, you know, inhaled pulmonary vasodilators. And then if those, you know, are not enough, and then you can continue on here, and you can see we can work our way all the way through to indicating for ECMO or continue with the same management. And then also, you know, you'll see right there in the decision tree, right in the middle is do they have anything that is contraindicated for ECMO? So we're still supposed to really be, according to ELSO, be looking at the contraindications for ECMO. And we know that those kind of went out the window for some parameters as this pandemic went on. Okay, looking a little bit at the just their list of indications and contraindications. They specifically have adapted this for COVID-19, but it will follow most of the regular parameters that they've already established. And so, of course, it's an age greater than 65, obesity, BMI greater than or equal to 40, immunocompromised, advanced chronic underlying systolic heart failure, and we can just continue to go down the list. Those are all relative. Now, absolute contraindications, advanced age, if they score on the clinical frailty scale greater than or equal to 3, ventilation greater than 10 days, which I think we've all decided that that's probably too long. We've been trying to follow, less than 7 days, and most recently, as soon as they're intubated, a day or two, if it doesn't look like it's going to go their way, they're going ahead and talking about ECMO on a lot of these patients. Uncontrolled diabetes or other end organ dysfunction, advanced lung disease, let's see, any of the other sort of interesting ones. Of course, severe acute neurologic injury, uncontrolled bleeding, any contraindications to anticoagulation, which of course a lot of these patients are very coagulopathic, and so they're bleeding a lot or they're not bleeding enough and they're throwing clots. So that's been really interesting to see how that plays out. And then, of course, any ongoing CPR. Okay, and here was the contingency for, I think I clicked one too many. Let's go back one. There we go. Contingency for how to manage these ECMOs, because again, they didn't know how busy we were going to get, right? This came out in the middle of the year. So conventional capacity, you just, everything's running fine. You just continue with your normal ECMO selection. You're able to offer all sorts of ECMO, VVVA, ECMO for non-COVID, and eCPR wherever it's normally offered. Then once you get to capacity tier 1, you are having to expand your capacity, you're triaging to maximize your resources. You're still offering, VVVA, ECMO in younger COVID-19 patients with single organ failure, and then being careful with your use for non-COVID patients, and then eCPR not to be offered. Really just kind of holding on to your resources there. Then when we get to the next plan, we've got the capacity tier 2. Your capacity is saturated. You need to have very restrictive ECMO criteria. You're prioritizing your non-COVID ECMO candidates. Your VV is only younger single organ failure. Your VA and eCPR are not offered at all, is what the recommendation is. Then once you're to your crisis capacity, you may not even be able to offer ECMO. Maybe you're out of resources completely. You're out of machines. You're out of people. You're triaging your ICU admissions. You're ceasing all futile care to create capacity in the system. Now, I don't think we ever reached the crisis capacity, but I would be interested to hear what you think about, especially in your busy center, John, if you think you reached capacity tier 2 or if you were just somewhere around tier 1.
Well, we've never not been at least in tier 1, I can tell you that, but we were, I would say one caveat there is that we never eliminated the possibility of eCPR, so I'm not sure where they throw that in. I mean, if we had a patient who was on the bubble and on the floor in a unit, on the bubble of needing ECMO or not, and we had met the criteria of age and whatnot, and that person went downhill suddenly, we went up with, we still do, go up with whatever equipment we had available and put that patient on. So I'm not sure why they're recommending no ECPR if you have the capability and a patient is there in your hospital. But yeah, we're definitely, we didn't get to crisis mode, I don't think, but we, you know, we're referred, so many centers refer to us. And we get, well, I should say we, the ECMO surgeons here, get calls almost every day that they have to turn down. We just can't take, you know, we've had to tell for a week or two at a time, even more, that we just can't take any outside patients. We have enough of too many of our own and some on the bubble so close in-house that it doesn't make sense. But as soon as we have the opportunity, we take some more in from the outside.
Well, I know we were for a while, you know, getting someone off ECMO, or maybe they were having their care discontinued, and no sooner than that machine had been cleaned and put away did we get another call of, you know, in-house patients, not even necessarily transfer patients, needing that machine, and several that were kind of waiting in the wings where we were, you know, at capacity on what we had available at the moment, and everyone kind of wondering, are the, you know, who's going to get better and who's not, because we have a whole line of people waiting, you know, to possibly get this kind of support and need this kind of support. So it looks like we got a lot of comments going on here. It looks like Joe and J Cam, I don't know your first name, sorry, are having a really lengthy conversation here, so I'm going to leave them to that, but it sounds like we've generated something that they're interested in. They're talking about the PF ratio and having it be less than 150 is what they're discussing right now.
Well, I don't know if you could, do you have any more slides? Are you done?
Yeah, no, actually I do. So let me go ahead and just click through the end here. Okay, this I thought was really interesting. This was actually at the front of the consensus article that was guidelines that were issued, but I put it at the end because I thought it would give us something to talk about, and I'm just going to read you, not the whole thing, but just something kind of towards the end. So it says, let's see, these guidelines are not meant to replace sound clinical judgment or specialist consultation, but rather to strengthen provision and clinical management of ECMO, specifically in the context of COVID-19. I thought that was really great because so many times, you know, we're looking for these guidelines for inclusion or exclusion, and we really want them to lay it out for us. But as nice as it is to have something to, you know, if you have an overwhelming amount of patients needing care, something to help guide you. But really, it comes down to, you know, the clinician, the physician, you know, the cardiovascular surgeon, whomever it is who's taking care of these patients, to really try to determine, is this someone, from my clinical judgment, that we need to go ahead and do or not do? And I feel like sometimes they've gotten that right, and they really, you know, took someone that maybe fell outside the parameters, and we've had successes. And then sometimes, even when they've fallen in the guidelines, they weren't really good candidates, but we put them on anyway, and, you know, without success. And so I think it's important to remember that you know, all of these guidelines are great to have, but it really comes down to, you know, using the guidelines as guidelines, but clinical judgment needs to be the most important thing. What do you think about that?
Yeah, I mean, I think they hit the mark on most things. One of your first slides, I wanted to have a talking point because they talk about age, you know, greater than 65. We pretty much stick to that. In fact, we may even, I think we use age 60 and below. I don't think we go as high as 65. But, you know, the thing about all this, and the BMI of 40, I mean, we in every place that I know of has to go over BMI of 40. Mm-hmm. I mean, that's just, you guys, that's probably your routine patient is over 40.
Yes.
BMI, and way over 40 BMI.
Way over 40.
But you can't hold yourself to that. When you have a 29 or 39-year-old, you know, young adult with 2 kids at home, the BMI is over 40, is 45 or 50, you know, I don't think you can say, oh, well, we're not going to do ECMO because they got COVID. You know, they try to give you some guidelines. I mean, I think you have to use them as rough guidelines and use your own. You know, you're in a war zone. There's a fog of war. You know, there's things that you're going to have to go outside of and do, and then and one day look back and say, wow, you know, I'm glad we did that, or maybe now we see maybe we shouldn't. But you can't just be. You have to be you have to be as judicious as you can, but you really have to stretch some of these boundaries. Otherwise, you're just not gonna. You're not serving some of these people well if you don't make some exceptions. I think, and I think we all see that, you know, to some extent. And but I think gives people some good guidelines at least to kind of go by. And and the other thing was, you know, they're saying, you know, to make sure you've done everything you can, including proning, before you use ECMO. And so here's what my talking point was, because that was one of your early slides there. You know, so where are we between doing it too soon and doing it too late? I mean, it's such a narrow window there. And I think we've actually, maybe in the beginning of COVID, we did it maybe a little bit too early. And I think now a lot of times we're doing it a little bit too late, and we're having a lot less success because the patients that are going on ECMO now are pretty far down that line. They've been on the ventilator a while. They've been prone several days. They've, you know, their whiteout X-rays and CT, ground glass, opacification and whatnot is substantial. And now we go to ECMO and let's see, you know, and I think you guys have probably seen the same thing where what you were saying about equipment becoming available, unfortunately, a huge percentage they come available for the wrong reason. You know what I mean?
Right. I do think we're seeing a little bit of a swing here where we had, in the beginning, they were responding quickly. They were doing a lot of proning once on ECMO, and then we started seeing, well, maybe we should prolong it, and so then we were waiting longer periods of time to put them on ECMO. But most recently, in the past couple of months, all of our patients have been early triggers, maybe one or two outliers that got transferred in after the fact, after they were already vented for, you know, a week. But quite a few of ours, it's, you know, vented and even maybe the same day put on ECMO, or if not the next day. And we're waiting to see how those are going to turn out. It's still early in our care for these patients, but I'm not really sure why. We had better success rates in the beginning, that's for sure. The sort of second surge that, you know, has died down for us a little bit here was, you know, very unsuccessful, as Joe has mentioned. I think at some point he's going to give a talk on the actual numbers that we saw for success rates, and they really weren't great for the second surge at all.
Yeah, and you know, we're up against a severe, you know, resource, you know, constraint. You know, you have so much equipment and so much personnel and so many rooms that you can put an ECMO patient in. You can't just scatter them all over the hospital. In our case, they have to be all in one unit where the CCM is ECMO specialized, and the ECMO specialists and nurses are all, you know, in one place. And so you start spreading them out. We tried that for a while, and it worked. It was difficult. We had such an overflow that we had 2 different units of ECMO, and that was really staff constraining. So it's got a little better. We expanded our ECMO unit, but you still have equipment constraints. You have to have backups. You can't just have every person on every equipment you have. You have to have backups, so many backups for how many patients you have, because things do go wrong and you have to suddenly switch it out.
Well,
so,
and, you know, we experienced that too,
we're
John.
looking at hour to hour a lot of times.
Yeah, that's absolutely true. We did experience that as well. You know, we, of course, had more than one hospital where we were supporting ECMO, but even within one hospital, at one point when we were, you know, really at a high point in the second surge, we had 2 units. Now, thankfully, they were stacked right on top of each other, but they were a floor apart because the one unit was where we were keeping the COVID ECMOs, and that became full. So then we were on the floor above it, and they, you know, they sectioned off some rooms up there for COVID. And then we had a regular non-COVID VA ECMO, which was, way across in another building within the same hospital in the CV ICU unit. So we actually, within one facility, had 3 different floors, locations that we were managing, and that's tough to do, especially when you have 3 or 4 patients on each floor. You're running up and down, and there's no way to even get to the CV ICU in a fast enough turnaround, so it might as well have been across the street, and saving the equipment for that. We had to reserve equipment for, these ECMOs that can occur with the surgeries that are going on, and even though we had patients who were, lined up and doctors wanting them to go ahead and let's use that other machine, let's use the last few machines to go ahead and put some of these VV ECMO patients on there for COVID, but we didn't, and thankfully we didn't, because you never know when you're going to have something come up unexpected, like a VA ECMO from surgery or a TAVR that didn't go quite as well. I mean, I know that a lot of places have been doing them for a while and mostly go without complications, but it's not 100%, and we saw that.
Exactly. You just can't allocate all your equipment away to the ECMO COVID patient and have nothing for other things. It's impossible. You'd have disaster on your hands. Mm-hmm. We do a lot of TAVRs, and they go very well, and every now and then you have to go on pump. And same thing with our lung transplants. Some of our lung transplants need to come out on a cardio help. Some of our heart transplants might need to come out on a cardio help or an ECMO device. You can't just give them all away to the COVID patients, and of course you have to have backups in case there's a equipment failure, which you're going to see, because they're going to be on ECMO a long time. That's another thing. You designate your equipment. It's not 2 or 3 days. It's 2 or 3 weeks, month or two. That equipment's running on an ECMO patient that may get to a point where they're not coming off ECMO.
Right.
They're at the end of the bridge to nowhere road, and now we're stuck. You've seen that many times.
Oh,
so
yeah.
The equipment consideration is a very, very serious one.
I mean, we had, one patient, it was such a sad story, went the normal 2 to 3 weeks and kind of thought we were going to see something, and we didn't. And then it was, a real sad family situation. They had already lost other family members to COVID, and so it was a very, very difficult situation to be able to get this family to a place where they really understood that this ECMO was not going to do what we needed it to do, what they wanted it to do for this patient. And that was another 2.5 weeks of support, So we were rounding out 6 weeks with this patient that we had known for at least, for sure, for 2 weeks or maybe 3, that we were going nowhere. Real quick, I'm just going to break away, and Jeff is the person who's commenting with Joe, so thanks for letting me know, Jeff. Joe just wanted to remind us that, ECMO's not without its own risk and complications, and that's so true. He also said, the outcomes were way worse than influenza or aspiration-associated ARDS, and I think you can agree with that too, John.
I think all of our previous non-COVID patients probably had a better survival. I don't have numbers in front of me. I haven't seen numbers at our institution, but it doesn't take a rocket scientist to look around and see how many per week, sometimes more, that we're turning off. Anecdotally, you just know that this story is not a good one. I don't know what the exact number is, but it's probably significantly worse than our flu A, flu B, aspiration, asthma, near drowning, you name it. I think all of those we would crave for those days of success.
Yeah.
With COVID. Yeah.
Well, Joe, Jeff, do you guys have any more comments you'd like to talk about? Joe's talking about it's a 60%. I think he's referring to influenza or aspiration-associated ARDS. 60% versus a 20% survival with COVID is, I believe, what he's referencing there. But if we don't have any more comments on this, we'll go ahead and I'm just going to read something from this ELSO guidelines that may be a little bit uplifting, that we can kind of close out our discussion today about Ecmo implications and contraindications, inclusion, exclusion, and how COVID-19 has sort of impacted that, followed those guidelines, not followed those guidelines a little bit, and we still don't really know, if any of it even made much of a difference. So there was a very nice foreword written by the president of ELSO, Mark T. Ogino. I hope I'm saying that correctly. He goes into, kind of a whole thing about it's spring and there's flowers blooming, and he's elated, to see the flowers coming out, but he knows that the season is going to be unlike any other. So this is last spring. But he closes this with a really nice thing after talking about, all the unknowns we're going to face, how frontline healthcare workers, just are going to be fighting the battle with these patients, trying to take care of them. But he ends with, the resilience of the human spirit will prevail. Spring will continue to thrill us. Society will adapt and endure. I thought that was a really nice way to end our discussion here today. So, well, let's see.
Awesome job, Tammy. Awesome job, Tammy. Are you guys interested in going into the Knowledge Nuggets segment? Or?
Yes, I'm ready. We're ready for John's Knowledge Nuggets. So, David, can you bring up the intro? Okay, and we're back. John, I will hand the floor over to you.
All right, awesome. So let's see if David there can key up the slides, and we'll see what surprise we have in store for us today. So, yeah, this is Knowledge Nuggets. I'm your host, John Ingram, John Ingram Knowledge Nuggets. For those of you who may have watched in the past, this is episode number 7. We launched this idea, I guess, in 2021, right, guys? January.
Yeah.
It's now April 22nd, 2021. As always, I have no disclosures on any topics today or any other day. So our motto at Knowledge Nuggets is, the reason why we have it named this is that you're going to spend a little time and expand your mind. Hopefully it's just going to be a good, informative, short, sweet, something that you can benefit from. And this week's topic is going to be Bivalirudin, also known as Angiomax. So as you know, if you've watched before or not, but if you're wondering, our format is different topic each week. It's actually every other week, but it's going to be something I hope that you can take home with you and be a better clinician tomorrow. And when you see a golden nugget in the right-hand corner of a slide, that's kind of like a take-home slide. Screenshot that, snapshot that on your phone. It's a nice little piece of information you might be able to be used in your practice up tomorrow or very soon. And it's just a 12 to 15-minute high impactful segment. At the end of that, we always have a surprise, which I call Perfusion Gem of the Week. You never know what you're going to get in a 2 or 3 minute segment about something highly interesting and hopefully fun to talk about. After that, we have panel discussion and questions. And of course, now or in the future, if you guys watching this live or in the future, you have any email questions or comments, please reach out to me at john.ingram@perfweb.us. And I do and will respond to everyone who sends me an email through that email address. All right, so what is Bivalirudin or Angiomax? Well, we can define it, and this is a little bit of a take-home slide if you're wondering exactly what it is. Bivalirudin is a specific and reversible direct thrombin inhibitor. A lot of people like to call them DTIs, direct thrombin inhibitor. It is a synthetic 20 amino acid peptide with the chemical name of, you can feel free to have at that. And that's actually the chemical configuration. Well, defining it further, the active pharmaceutical ingredient is in the form of bivalirudin trifluoroacetate. It is a synthetic congener of the naturally occurring drug hirudin, which I think most people know is found in the saliva of the leech Hirudo medicinalis. Okay, medical leeches. It's found in their saliva, and one of the reasons why they're able to do what they can do is that as they draw the blood out from your skin, they keep it from clotting. Very wise, very good adaptive animal evolution there. Well, the blood will not clot on them, so it's productive for them to be able to keep the blood anticoagulated on the isolation, on the spot where they're drawing from, and it doesn't clot, and they are able to retrieve it. So a DTI, it's a DTI that overcomes many limitations seen with indirect thrombin inhibitors, such as heparin. It's a potent and highly specific inhibitor of thrombin, hence its name. It inhibits both circulating and clot-bound thrombin, and it also inhibits thrombin-mediated platelet activation. So it's a very nice anticoagulant in that regard. Further defining it, it has a quick onset of action, we're going to talk about that, and a short half-life. It's supplied in a sterile white lyophilized powder as an off-white color in a single-dose vials. Each vial contains 250 milligrams of bivalirudin, and this is equivalent to 275 milligrams of bivalirudin trifluoroacetate, which is what you actually end up with because it has 125 milligrams of mannitol and sodium hydroxide to adjust the pH to between 5 and 6. When it's reconstituted with sterile water, it is relatively clear, pretty much colorless, sometimes a slightly yellow tint in the solution once you reconstitute it. So if you look at the coagulation cascade, because we're talking about thrombin, we see there you have the intrinsic pathway and the extrinsic pathway, but they come together in the red there at the common pathway. And go ahead for the next slide, Dave, and you'll see there that thrombin, this is what this anticoagulation, the direct thrombin inhibitors, this is where its mode of action is, in inhibiting the formation and the continuation of the coagulation cascade right there at the site of activating thrombin. So what about thrombin? Let's talk about that a little bit so we can understand what an anti-thrombin, direct thrombin inhibitor is doing. But thrombin and its role in coagulation, it's a serine proteinase that is central to the thrombotic process. As you saw there, it's on a central line mainstream to forming a clot. It cleaves fibrinogen into fibrin, and it activates as well as cleaving fibrinogen into fibrin. It also activates factor 5, 8, and 13. And so it further stimulates the coagulation process. It has what they call backfeed or ramification effects, and further stimulates other factors in the coagulation cascade to continue their activation. But it also allows fibrin to develop a cross-linked framework that stabilizes the thrombus. So the fibrin, as you guys know, comes in around the platelets that are being plugged up and forms a heavy-duty meshwork and really stabilizes that thrombus or that clot. So if you can prevent thrombin from forming fibrin into fibrinogen, you don't have a good clot going on at all. So thrombin promotes, go back 1 second, on that last line there, thrombin promotes further thrombin generation, and it activates platelets and stimulates aggregation. So if you can, again, stop thrombin from doing that, you have all these benefits of stopping what thrombin is trying to do. Okay, Dave? So what is the clinical pharmacology? If you want to know a little more, it's a take-home slide for you here. The mechanism of action, it directly inhibits thrombin by binding both to the catalytic site and to the anion binding exosite of the circulating and clot-bound thrombin. So those are the sites on the thrombin where it binds to. The binding of bivalirudin to thrombin is reversible, though, as thrombin slowly cleaves something called the bivalirudin ARG to Pro4 bond. Regardless of what that actually means, and you can read up on it, what happens is the thrombin is basically able to self-recover from its effect that the bivalirudin is having on it. The thrombin is not permanently bound to the bivalirudin, and it works to reduce this bond of bivalirudin that is attached to its activation sites and basically recover itself and become again an active thrombin cell again. So now the pharmacokinetics is that bivalirudin is cleared by a combination of renal mechanisms, basically through the kidneys, and proteolytic cleavage. So the half-life of bivalirudin in a normal functioning renal organ is about 25 minutes. And a mild renal dysfunction, whatever you define that as, it could be prolonged, maybe like 29 minutes. Moderate renal dysfunction is going to be longer than that, somewhere around 34. But somebody in severe renal dysfunction, it's going to basically more than double the half-life of bivalirudin. And this is important because if you're giving somebody bivalirudin, and we're going to look at how you give this, the bivalirudin is going to continually to accumulate if your body is not eliminating it at the expected rate that the dosage was determined to be. So, but once you discontinue and start discontinuing the IV infusion of the bivalirudin, the coagulation times will return to normal in about 1 hour in a normal functioning renal organ patient. So what are the indications for use? Well, it's indicated for use as an anticoagulant in patients. Basically what it's indicated for is PCI, patients going under percutaneous coronary intervention, angioplasty, and stents. It has a provisional use as a glycoprotein inhibitor, a GPI, which is basically your antiplatelet drugs. It basically acts as an antiplatelet drug, but it's not considered to be given for that reason. It's only under a provisional usage that you can give it for that reason. So it's indicated for patients at risk, of course, for HIT, heparin antibody, and HITTS, and for patients that have that syndrome and they're undergoing percutaneous intervention, coronary intervention. Bivalirudin is intended for use with aspirin, and all the studies that were done on it were only on patients that were receiving aspirin. In all its FDA approval studies, bivalirudin was given with patients with aspirin. So the contraindications are basically your bleeding indicators for the most part. Anybody with active bleeding, patients that are hypersensitive to bivalirudin. And as far as pregnancy is concerned, it's classified as a category B drug in cases of giving to someone who may be pregnant. And what category B means is that on all the studies on animals, it has not shown to be harmful to the fetus or to the mother. And so all indications are that you could give it to a pregnant woman, and it can only be given to in pregnancy in a severe case. But if you do, it's considered that all indications are that it does not cause a problem. So there's side effects. 80% of these, if you read them, have some type of bleeding complication. Blood in the urine, bleeding from a wound, nosebleed, bleeding gums, and all this stuff. Any type of bleeding side effect. But you could also have an allergic reaction like hives or difficulty breathing, swelling of the tongue or throat. You could also have swelling in an arm or leg, which may mean you have a paradoxic effect where you actually have clotting or problems with vision or speech, which again is probably getting some type of TIA going on. So these are all mostly obvious that you're going to have aggravate current bleeding situation by giving somebody this type of anticoagulant. So what is the dosage during a percutaneous coronary intervention, PCI? Well, it's pretty simple. You basically know the person's kilogram, and you give a 0.75 milligrams per kilogram. And for a continuous infusion, because that's how this drug works, you give a bolus, and then you immediately follow it with a continuous infusion, IV infusion. And in the case of a PCI dosage, it's 1.75 milligrams per kilogram per hour. So one thing I found interesting was, and this is more of a a nursing thing, but I found it interesting that you cannot give somebody this continuous IV administration of bivalirudin in the same line with some very interesting drugs, because these drugs, a lot of them are common to the patients that we see. For example, you cannot give it in the same line as amiodarone. You cannot give it in the same line as diazepam, dobutamine, vancomycin, streptokinase, and some of those other ones there. And I found that was interesting, because a lot of times these drugs, the ones you can't give it with, are a lot of the ones that a lot of us don't deal with or you've even heard of, but I still hear that some of these are pretty common. So you have to watch out if you're supporting a cardiac patient, as you might be in the cath lab doing a PCI, that you can't go in the same line as someone getting some of these supportive drugs. So what about cardiopulmonary bypass? So the next few slides I'm going to focus on, some people have done, and you see papers being out there, but a lot of people have no experience with giving a patient going on bypass without any heparin. In fact, just totally with Bivalrooted. And, what would I give? What would my dose be? How do I manage it? All these questions you hear. Well, backing up, though, it's primarily metabolized by thrombin, by basically the thrombin itself, freeing itself from the active sites and becoming active again. It's metabolized by the thrombin and by blood proteases. Potential coagulation when the blood stagnates. That's what you have to remember if you're going to put a person on bypass. It's very easy and it doesn't take very long if you have stagnated blood for the blood to coagulate. Because remember, it's only got a half-life of 25 minutes, and that thrombin is working very diligently to reinstitute itself as active thrombin. So stagnant blood becomes very concerning when you do a Bivalrooted on bypass. So what are some of the places you have to be concerned about? You have to be concerned about your cardiopulmonary bypass filter, the surgical field, cannula tips when you're off bypass, the cardiotomy reservoir if you're doing cell saver, okay? All of these things. So whenever you have stagnant blood, it's the pool blood is easily could gel in the surgical fields, down into the pericardium and so on, where we always have blood accumulate. You could have clotting there, even though you have sufficient levels of Bivalrooted anticoagulation. When you have stagnation, you could actually have clotting right there where the blood is stagnant. So for on-pump procedures, what are you going to do? You're going to draw a baseline ACT like you normally would prior to giving the Bivalrooted, and you're going to multiply your ACT baseline times 2.5. We're not doing 480 anymore. If you have a baseline ACT of 100, you're going to multiply times 2.5. Your ACT during this case is going to be 250 seconds, or whatever 2.5 is. Forget about the 480 that you're all used to with heparin. This is a whole different scheme now. Your initial dose is 1 milligram per kilogram bolus. That's very simple. But you then immediately, and this goes to the anesthesiologist, continuous infusion of 2.5 milligrams per kilogram per hour. Or I suppose that could be done into the pump. But you also are going to put 50 milligrams in your pump prime. Okay? This is a take-home slide. Like I have the golden nugget there for anybody thinking about, can I do a case on Bivalrooted by itself? Also, you have to consider a lower doses in renal, liver, and or significant heart dysfunction, renal failure, liver failure, because it's not going to break down the Bivalrooted as rapidly. Also, the note, cell saver or other parts of the circuit where blood is collected but not directly circulating should have citrate added, sodium citrate added, right? You're not going to use heparin. The whole reason that you're using Bivalrooted is that you have a HIT patient that has a heparin allergy, right? So you can citrate your cell saver blood. Now, what about off pump? Well, you can do Bivalrooted off pump, and it's basically about 3/4 of the dose of an on pump procedure. If you notice a minute ago, I said your initial dose on pump was 1 milligram per kilogram. It's 0.75 bolus for off pump, and it's 2.5 milligrams per kilogram on pump, 1.75 milligrams per kilogram per hour off pump. So basically 3/4 of the dose, both bolus and infusion rate for off pump procedures. So you have to think about adjusting your dose while you're on bypass. You may. If you have subtherapeutic ACT levels below that 2.5 baseline that I mentioned, you're going to have to adjust your infusion rate, and you might up it by 0.25 to 0.5 milligrams per kilogram an hour to keep your ACT at your goal. You may just have to give a bolus on pump. You may not have time, if your ACT is dropping too low below your target, just upping your infusion rate. Well, that's going to take time before you get a higher circulating volume in there. You may have to give a bolus, and you want to think about something between 0.1 and 0.5 milligrams per kilogram as a bolus directly into your pump to keep that get that ACT back up there. What if you have supratherapeutic ACT levels? Your ACT levels are climbing much too high. Well, obviously you're just going to start lowering your infusion rate. But if you have a more emergent need to remove the anticoagulant effects, okay, ultrafiltration works wonderful with Bivalrooted because it does come across the pores of the filter. So ultrafiltration, if you start ultrafiltration, you'll really expedite your reduction of your Bivalrooted levels if you feel they're getting too high. How do you avoid complications on bypass? Another take-home slide if you're thinking about bypass. You should use closed systems whenever possible to minimize stasis, right? A venous reservoir bag is going to be all part of the movement of circulation a little better than an open reservoir where blood can sit a little bit stagnant at the top and moves a lot more quickly at the lower part of your reservoir. So closed systems are recommended. You need to saline flush the veins. They're talking about up on the table when you do your grafts and you flush the grafts with blood to test them and stuff like that up at the table. Don't use blood, use saline because that blood is likely to be static inside the vein for a while. Could clot off your vein graft. They actually recommend running low blood levels in your venous reservoir. You're going to have to be judicious about this, but again, if you have a lower level, what's coming in is rapidly being pumped out. You're not going to have stasis in your reservoir. There's more things you have to consider. Give cardioplegia every 15 minutes instead of 20 minutes or longer because you have to keep flushing that cardioplegia line every so often to make patency, to keep it patent or from clotting. Any blood-filled recirc lines or any lines in your system that are generally clamped but have blood in them, you need to flash them. You need to open the clamp and flash them at least every 15 minutes. Avoid stagnation for too long. And also, you shouldn't do hypothermia. They recommend against that because what you're doing is when you go cold temperature, remember that the metabolism of the thrombin itself is working to free itself from the bivalirudin. The dosage that you're given, that infusion, is because the pharmaceutical reaction knows that you're constantly eliminating the effectiveness of the bivalirudin off of the thrombin. It's freeing itself from the bivalirudin. So you have to have a constant infusion going. If you cool the patient, that slows that enzymatic process down, and now you're going to have an overabundance of your bivalirudin on pump because you cooled. Does that make sense?
Mm-hmm. Yes.
Yeah.
So now how are you going to come off pump? This is interesting because, while this is reversible, you can't give protamine and reverse it. This is going to be a process before this bivalirudin wears off. There's a half-life and a process that has to happen. So what they recommend is you stop your bivalirudin at least 15 minutes before coming off the end of bypass. You consider ultrafiltrating 30 to 60 minutes prior to coming off bypass to remove some of that excess bivalirudin. Now you have to be very careful. You have to keep monitoring your ACTs here. It's not just time to, hey, let's get rid of all the bivalirudin, but you're trying to work yourself to more of a minimal standpoint so when you come off, you've got less for the body to take care of on its own. You're still on pump. You can do a few things like ultrafiltrating for one thing. Mm-hmm. But once you're off bypass, they recommend that you take that arterial cannula out of the aorta and move it over to the atrium. Or just give blood through the venous line, I suppose, but you do not want to have, 10 minutes go by with the arterial cannula in and, give 100 like we all hear all the time. And meanwhile, the arterial cannula has clots in it, and now you've just stroked the patient. If you're giving up the right atrium through the venous line, if you have that ability, or move the arterial cannula to the right atrium, and that happens, well, at least the clots are going into the pulmonary system where largely they can be filtered out and trapped, and it's not going to the brain. You have to consider these things. With the stagnation, you always have to be very cognizant of it. So you continue your ultrafiltration, as I said, but actively keep monitoring your ACTs that you don't get your ACTs too low. If you need a rescue option, low-dose recombinant activated factor 7 has been used as a potential rescue option. You get yourself into a bleeding situation, you have too much bivalirudin, you're off pump, you're bleeding, what are you going to try to do? You can try to give some factor 7.
John, if I can interrupt you for 1 second. I see that we're supposed to stop the infusion 15 to 60 minutes. That's a huge time range. How are we deciding? Is it just by running your ACTs? How low are you allowing the ACTs to get below 2.5 baseline?
Yeah, I was going to stop and comment about that line, and I decided to keep going because that's a real wild one. I mean, that's a big window of time. I personally haven't pumped a case like this, and my feeling is that this is something that people must gain with experience. I certainly would be pretty perplexed if I stopped the Bivalrooted thinking we were going to come off in an hour, and then it was longer than that. So I think I would start with the 15 minutes and gain experience with what you know at your institution. But yes, I mean, if you have a very high ACT, if you're far and above that 2.5 times your baseline, I suppose you could say, well, this case, maybe I'll stop at 30 minutes before we come off, and I'll keep watching my ACT and see. And unfortunately, I don't have a good slide here where I can tell you, this is the range plus or minus. Maybe we have a caller or a viewer that has a lot of experience with doing this and see what they do, because normally you want your ACT within a range, right? And we really don't have that pinned down here on this presentation. I didn't find that anywhere when I researched this, but I think that you just have to gain that with experience would be my guess. But somebody could call in and give us some better education on that.
Yeah, if anyone out there does have experience using this and has some comments about gauging, when to stop the infusion, or if that's just something that is patient dependent and you sort of just get a feel for it, please let us know. Please call in. David, if you could throw up the call-in number so that they can see that, and maybe somebody will call in and answer that question for us. Sorry to interrupt.
Tammy, I think that, if it was me, it says there stop by Bivalrooted. I think maybe you cut it by half or something. You know what I mean? You start turning it down before you really have the confidence and experience of turning it completely off. And then I think there's no substitute for experience. But I'd be interested to know if somebody has experience with this. I personally haven't done a case, and I don't think I've seen a case done strictly with Bivalrooted. Have you?
Yeah, no, I have not.
Yeah. That's why I'm glad I found the guidelines, at least, that apparently there's people that have done it and have figured out. There's a lot to consider with the stagnation. It apparently is not very forgiving for very long, of maybe just maybe 5, 10, 15 minutes at the most of blood being stagnant, that the clotting can start to happen, wherever you're having stagnation. So it's pretty. I guess you got to be pretty on top of all aspects of your circuit and cannulas and whatnot, and even in the surgical field.
Well, yeah, that's what I was going to say. Even in the surgical field, where we have very little control over that, but that's definitely something to get used to. And I wonder if, rather than really trying to infuse, once you come off pump and you've infused the blood that you need to, I wonder if it isn't just better take that cannula out and just send your volume over to the cell saver. It sounds like really a lot to keep up with. It sounds kind of crazy, actually.
Yeah, it sounds like you might want to come off pump and just go right into sort of tanking up the patient.
Yes.
Pretty well, and working with the anesthesiologist, maybe leave the patient a little bit dilated, and then tanking him up, getting a lot of your pump blood in, getting those cannulas out, and then go with your cell saver and you tank up the patient somewhat and let the anesthesiologist then sort of manage the pressors. Hopefully, I think you have to. This is not something that too many of us know a lot about and have a lot of experience doing. I don't know anybody that does. It'd be interesting to see, but.
Well, we do have our call-in number up. Again, we invite you to call in and comment and let us know your experiences with AngioMax. If you have any additional guidelines or tips on how to manage this, I think it's very interesting. We do have Jeff commenting on YouTube. that he did use it once for open heart surgery about 15 years ago, but the patient bled and bled and bled. So that was his experience with it. And Joe was asking a little bit about if it was if ultrafiltration would help, and yes, you did cover that you know you can use that to help control your ACT, to lower your ACT if it's starting to get out of control there. So wow, that was a great topic, John. Thank you.
It really comes across the ultrafiltration pores, and so that is a pretty aggressive way to do it, and they recommend that if you get too much on board. And I think again, you might have to be careful that you don't overdo that, because it sounded like from the research that I did that you can remove some pretty significant amount of Bivalrooted through that ultrafiltrator. So yeah, some interesting things to think about there.
Yeah, I mean, even just thinking about the cardioplegia, really you're really going to have to be staying on top of that, hoping your surgeon is sewing quickly so that you're able to give your redose amount if needed, really every 15 minutes. And even, I started thinking about for those folks that use Del Nido, you're giving that initial dose and then the blood's just sitting there in your cardioplegia circuit. So you'd have to definitely think about that too if you, want to keep it open in case you need to give another dose later on. I know that's not that common, but sometimes you get into some of these complicated procedures. They go a little bit longer than that recommended, 60 to 80 minutes, and you might have to give a redose. I know I've done it before for sure.
All of your 4-to-1 blood cardioplegia systems, you give the dose, and it's usually what I think most people are 20 minutes dose, thereabouts. It depends. But they don't recommend that it sits for that long. They say that you're pushing the envelope at 15 minutes, and if you have nowhere to push that blood through the circuit, and the surgeon's not ready for it, I guess you're gonna flow. You have to flow several hundred cc's to get it from the beginning of the from where you're taking it from on your oxygenator through all of your cooling system and up to the table to flush it. I don't know. Are you flushing it into a bowl and suctioning it back to the cell saver?
I don't know.
I guess I don't know.
I don't know. Huh.
You wouldn't want to lose all that blood. It's quite a bit of blood, right?
Yeah, that's quite a bit of blood. Huh. Okay. All right. Well, I didn't mean to interrupt you. I think you were getting to the gem of the week, which
gem of the week might be coming up. I think there we go. So what we do with the gem of the week? Anybody who hasn't seen before, it's a surprise. You never know what you're going to get. It could be anything that I come up with, anything that pops into my brain. It could be a perfusion or medical trivia question or point of trivia. It could be how to conduct an interview nowadays, an online virtual interview. 10 tips to being successful. I could post an interesting job post that's out there that we could talk about that people might be interested in. It could be something like a product recall, something in the perfusion news. And by the way, the next one is our perfusion week is coming up in May. Right. So I may find something interesting there to pull from in the next couple of sessions. I could take a famous quote and we could talk about the implications of a very poignant quote that someone has made, which we did about a month ago. Or I could talk about an upcoming perfusion conference like the New Orleans conference. But this week's gem of the week is going to be, can you really die of a broken heart? And the answer is yes, you can die of a broken heart, and here's how. Well, there's many examples of it, but when Carrie Fisher died in the late 2016, the film world went into collective mourning. And try going back there and stopping that slide there, I'm not sure what happened. So the grief was compounded the next day when her mother, Debbie Reynolds, suddenly died, who was basically relatively healthy. And for many, it was a simple fact that that she was just in so much emotional turmoil and grief that she just, it was a very sad situation. But the very next day, after her daughter dies, she dies. And so what is the likelihood of that? And so we're talking about dying from an emotionally distraught, as you talk about in your relationships, I have a broken heart. We're talking about an emotional situation, not a physical disease, but it manifests itself. And so what we know, this is Dr. Stamp, an Australian cardiologist who was interviewed on this topic at one point and wrote an article. And when he was interviewed, this is what he said. He said, well, what we know is that for some people, the stress of losing a loved one or any kind of stressful event in your life, for example, a divorce or getting bad news about terminal cancer. I mean, there's a number of things that can precipitate this. And it does precipitate a whole bunch of reactions in the physical body as well as in your mind that can and do cause disease and sometimes can cause someone to pass away. A quote from Dr. Stamp, a famous Australian cardiologist, said that
Wow.
about this. So then, while the stress of grief may bring on general health impacts, there's a legitimate and specific medical condition, and this is called Takotsubo cardiomyopathy. Takotsubo is a Japanese word because it was discovered and described by a Japanese physician not too many years ago. So it's also known as, but that's the formal medical name for this. Takotsubo cardiomyopathy is dying of a broken heart, or heartbreak syndrome for the layman, let's say. But
Wow.
this is dying of a broken heart, but it is incredibly rare.
Wow, that is so interesting.
Yeah, we're going to look at this. So what happens? And here's Dr. Stamp again in this research paper that I read about on this and some others. But what happens is in an acutely stressful event, there's a massive rush of adrenaline, and it causes something similar to a heart attack. When it comes to Takotsubo, we do actually see all the tests. And he's talking about the the EKG and the echo and all the cardiac tests that point to somebody having a heart attack. But looking physically at an image of their heart, what you see is normal coronary arteries, but then you see this big blown out heart. Now he's kind of talking to the layman here, so we're going to look at it a little bit more medically correct in the upcoming slides. And here you go. So you have a normal heart on the left, and basically this is a manifestation, Tammy, of the left ventricle. So you see the normal heart there on the left, the normal ventricular size. And somebody who is suffering this severe emotional condition, the shape of the left ventricle actually balloons out and becomes enlarged. Now, we're talking about healthy people, 20, 30, 40-year-old people, any age, that does not have a heart condition. They suddenly develop this within a few days or so after this severe emotional event that they're going through. And the Japanese physician who described this syndrome, when he saw this on the echocardiography, said, wow, that ventricle is ballooned out. It looks like what they have in Japan, something called an octopus trap or an octopus pot. It's shaped like what they have over there, something called an octopus pot. Not sure what that is. I think it's a particular type of pot they use for plants and so on. But anyway, he described it, and that's what Takotsubo means, is octopus trap. And it's shaped like that for your left ventricle. And this is diagnosed on echo. Somebody who has broken heart syndrome, their symptoms are diagnosed on echo, and the shape of the left ventricle will be abnormally ballooned out like this and contracting relatively poorly. So can you die of a broken heart? Well, its surging stress hormones flood the heart and stop the left ventricle from contracting normally. It mimics a heart attack with chest pains and shortness of breath, and often can be misdiagnosed. Patients are not having necessarily a heart attack. But most patients recover within a couple months. The situation subsides, their emotional situation, begins to improve. But 1 in 5 people, Tammy, actually can die of this broken heart syndrome. They have it severe enough.
That's absolutely unbelievable. I can't believe it.
So this mythology that you can die of a broken heart comes from somewhere, and we've often thought of it as folklore, but it is a real physiology. Dr. Stamp quoting there again. Broken heart syndrome is also known as stress-induced cardiomyopathy or apical ballooning syndrome. You might hear it called that. So here you go, another little graphic from another article that I found. I know it's a little bit of a repeat, but here you have it's a temporary heart condition after an intense physical emotional event. And you see normal ventricle and ballooned out ventricle. And I'll state one thing here, and that is that women are 9 times more likely to have this occur to them than are men. But make no mistake about it, men also can do it and have had this syndrome.
Wow.
It is probably, heavily hormonal based, but this is an emotional condition. So can you really die of a broken heart? Well, it's rare, but believe it or not, we have approximately 200,000 cases per year
Wow.
in the United States. And it requires lab testing and really imaging in order to diagnose it correctly. The syndrome can last and linger for several weeks or months, slowly getting better over time, usually is what happens.
Wow.
What are the symptoms? Sudden onset of chest pain, shortness of breath, palpitations, nausea, vomiting. And Tammy, aren't those all exactly the same
Yeah.
thing you see when you're having an MI?
Yeah.
Well, the treatments are ACE inhibitors. They're basically going to help you reduce your blood pressure so the left ventricle is not working as hard against as high of a blood pressure. Beta blockers, you have this huge adrenaline rush. Your heart rate is probably up. Your beta blockers are going to slow your heart rate. So you're going to, try to decrease some of that tachyrhythms that you have going on. And then anticoagulants may be given for a short period of time, because if you have a ballooning ventricle, you may have some stagnation in the apex of the ventricle. You could have a risk of a stroke. So sometimes they will give you these three things where you have a decrease your chance of having a stroke and a clot eject from your LV. So there you go. So if you guys have any questions, comments, email me at this email that I mentioned earlier. I will respond to anyone who sends me an email there. And if you have any suggestions for an upcoming show, love to hear from you that on as well. So thank you guys so much for listening. I think we're ready for our panel discussion on Bivalrooted, or can you really die of a broken heart?
Yeah, those were great talks, and I especially like the gem of the week. That was really, really interesting because, of course, many of us have heard of dying of a broken heart. You even read about those stories. I didn't realize that Carrie Fisher and her mother died so close together. I remember it being close, but I didn't realize it was that close. But, you read about those human interest stories where, people who've been married for 50 years or more, and one of the partners dies, and shortly thereafter the other partner dies too, and everyone likes to believe it's because they were so lonely and died of a broken heart that they lost their life partner and their soulmate. So that's really interesting. It makes sense that it's a stress-induced injury because we know stress can play such havoc on our entire body. I mean, that's a real interest of mine, and it really is, that's not the kind of stress that I typically talk about, the chronic stress, the stressors in our lives that we don't find an outlet for. But I suppose some of the same techniques could be applied to these people who are suffering these very traumatic events, probably often unexpected, is, really trying to incorporate some of those coping mechanisms, whether it be support system or finding a physical outlet, running or exercising or even painting, depending on if you want to go the more adrenaline rush kind of stress reliever, or if you'd prefer the meditation, calm your mind, nature walks, painting, reading, those sorts of things. But, it seems like probably the people who get better either had less of a stress reaction, had a healthy heart to start with, perhaps, less of a stress reaction, or indeed did have some of the coping mechanisms because, of course, a sudden death or a death of a loved one, that's going to take a very long time to get over, usually more than a few months. And so to already start seeing recovery then seems like that those people must have had, some different situation, either in how they dealt with it or how their heart started out, initially.
I think this is, you make a good point about, daily stress, the stress of a very busy, multitasking person who's got a million things on their plate. They wake up in the morning, they're running 80 miles an hour from morning to night. They're doing a million things. They've got a million things to think about and do. And that's sort of your young professional, stress, your yuppie stress, your person who's got, everything going on. Or maybe it's just a not even professional life. Maybe you're raising kids and you've just got a million and one things to take care of all the time. So that's an ongoing stress. That's sort of an active everyday thing that I think maybe, exercise, diet, yoga, meditation, things like that. If you could find an hour of the day to do that, you're managing your ongoing stress. This is a sudden, devastating, never saw it coming, overwhelming, emotional, a sudden death in the family from something was totally unexpected. Death of a child, whatever. But it could be anything that was just so difficult for you to get your arms around. And you get into this deep plunge of an emotional feeling. And I don't know if it's ever happened to you. It's happened to me that I've had such a deep emotional catastrophic event that I felt like I felt something physical in my heart, in my chest.
Yes,
Yeah.
definitely. I've experienced that once before, and knowing what I know now, I definitely must have had some kind of incident going on with the rush of hormones and everything going to my heart. But at the time, maybe if you didn't know anything about it, because I certainly didn't know it was an actual, real physiologic thing going on, I thought I was inducing some sort of like anxiety attack or something, but yeah, it was very real. It was very uncomfortable. It was definitely a real pain, in my chest that I felt. So yeah, and nausea too, actually. Now that I think about it.
You didn't go into a ballooning of your left ventricle, but you had the initial surge of this overwhelming emotion, overwhelming adrenaline. I think it's more than just adrenaline. It's probably a multitude of other hormones, and just what are our psychological and emotional emotions anyway? What are they? We really can't put a tangible thing on them, but we feel them. They do something to us physically, which is why we cry and why we collapse and why we come to our knees and yell out, and all these things are, emotional is powerful. And at some point, if it's deep enough, sudden enough, and overwhelming enough, you're going to have physical manifestations. Now, you probably just had it for a minute, an hour, maybe even a day, but people that go through it and stay in that state for several days or a week, it will start to have a chronic effect on their heart, where this is what can happen. Like it did say, it was rare. And even people that do have it emotionally, get a little better and a little better with time. Maybe they're able to, digest things over time. So 2 or 3 months, something like that, that gets less and less, and their heart actually goes back to normal, and they have no permanent effect from this. But people who don't, or the emotional devastation continues to be so overwhelming, they might just die in a day or two or in a week. And as you said, people that have been married 40, 50 years, the percentage of the one who dies and the other one dying within 12 months is incredibly high.
Yeah.
Normally that person wasn't going to die otherwise if the other one had lived. The likelihood they wouldn't have anything wrong with them, or very little wrong with them.
That's usually what you hear, is that
they die also.
Usually in those stories you hear that the other person, didn't really have any illness. They might have had chronic illnesses, but nothing that was, with an impending death that was, just around the corner. So that people are always very shocked when those kinds of things happen. So Joe is just jumping back into the discussion here, and I guess he missed your gem of the week. So yes, Joe, we are talking about the broken heart syndrome, and he commented that the other person that they lost was the person living's purpose for living. I probably, when you've been together that long, you are very, your dependency on each other is very, very high. I mean, most of us aren't with people quite that long. I mean, think about when you're a child and how dependent you are on your parents. They, provide your home and guide your life and all of those sorts of things. And imagine then doing that as an adult, but for, many decades longer. I imagine it is just completely devastating. Your entire world turned upside down, for sure.
Yeah, I don't want to give the audience the impression that people who lose a loved one and they're elderly and they die within 12 months have died of a broken heart.
Right.
They've died of the loss of the willingness to live. They
Yeah.
no longer have the emotional will to live, and that is something different than this. But it would be interesting to know, they still have to die from something. They have to die from a failure of something that, to oxygenate the brain. And so I wonder how many people have looked into what physically really happens to these people who lose their will to live. I don't know how much percentage of those would be this particular syndrome. I have a feeling maybe not quite that many. But that would be an interesting topic for another day as well. But I don't want to leave the impression that, just because you lose a loved one, you die 10 months later,
Right.
that this is what happened to you. It probably is extremely rare. And this, I think, if you pass away from this, it's probably in a fairly short period of time, like weeks to several months.
I see.
Because you're basically gone into a pretty severe left ventricular failure, and you probably continue to get worse because your emotional state, rather than getting better, and you starting to get better from this, you probably continue to get worse.
Yeah, Joe's commenting here. I'm trying to figure out what he's talking about. I think he's asking us to, he's recommending a book. We're getting kind of deep here. It's Man's Search for Meaning by Viktor Frankl. So I guess he's recommending that for our reading time, John, so that we can get caught up on what we're talking about here. Thank you, Joe, and we will keep that in mind.
Yeah, absolutely.
Well, I guess we're not going to have any callers call in about either broken heart syndrome or angiomax or their experience with using angiomax, which is unfortunate because this was supposed to be the Tammy Sparacino, Tammy Sparacino Journal Club Casino, and we were going to spin for a winner. We did that for the spring conference, and we had a couple winners, but this was going to be the real inaugural first time. So maybe we can get somebody to call in, even if they are have already called in before, so we can get this done. Oh, look, we have a caller.
Well, so okay, got a caller. I got something I can tell you.
Okay.
But something even better coming for future Tammy Sparacino Journal Club Casino wheel. We have some additional perfusion products and T-shirts and sweatshirts and hats that were donated that are on the way and shipping now. So next time we have this, there's going to be real sweatshirts, T-shirts, and hats as a really cool design. We'll have to see.
That's great. That's great. Well, that is definitely something to look forward to. So do we have a caller?
Yes, Jeff.
Joe, is that you?
Well, Joe called in, but I called in too.
Jeff. Oh, sorry, I couldn't hear you. Hey, Jeff, thanks for calling in.
Joe flyer on the show now. That's great.
Joe said he's calling too. I don't know.
Yeah, well, thanks for calling. I'm glad I'm not talking out into the void out there, just John and I, with our own musings about broken heart syndrome. Okay, did you have a question or a comment?
Hey, so I didn't know if anyone had experience or John has seen this because it seems like he does a lot of Ecmo down in Tampa. The use of angiomax in Ecmo.
Yeah.
Like routine use of it, not just in case of like a patient that develops HIT on Ecmo, but just routine use of it in Ecmo compared to heparin.
Mm-hmm.
Yeah, I was gonna talk about it on Ecmo, and I decided to go and do something. We do a lot of Ecmo talks on the show, so I decided to talk about it on bypass. But you actually are seeing it at it's not uncommon on Ecmo. It's not uncommon on Ecmo. I know places that do strictly angiomax for their Ecmo, and basically you want to start off with an infusion and get your PTT. You want to use your PTT and do your 1.5 times baseline range of 40 to 60 or something like that, whatever your 50 to 70, 40 to 60 range, what your institution likes to use. And then just keep your rate. And once you find that sweet spot, with Angiomax, you'll find that it keeps you right on the rails. People love it. You're not swinging up and down like you do with heparin. You're not getting heparin resistance. You don't have the thrombocytopenia that you have with heparin. You know, the big downside is you can't reverse it, but its half-life is 25 minutes. So once you get your PTT right where you want it and you have that infusion rate set, I bet you leave it there for days on end without having to adjust it. So
John,
people love it for that on that.
let me interrupt for just a second. I think we're getting feedback from your viewing the show, Jeff. If you wouldn't mind turning down your volume while you're on that call.
I just muted it, whatever.
Oh, wait, I'm sorry. Could you repeat that? I missed what you said there.
I just muted my computer because I couldn't hear it myself.
Oh, yeah. Okay. So did John answer your question? He was talking about, you know, relative management of it. It really, I guess, John, you were saying stay stable once you find your sweet spot.
Yeah, I mean, I've never used it. I mean, we thought about using it in the past for him. We ended up, due to the cost of it, we ended up just using our Atropine and had pretty good success using that. So I don't know. I just wanted to see what people were doing. I know specialty care. They seem to use a lot of their accounts. I don't work for specialty care, but that's what I've been told or whatever. So I didn't know.
Yeah.
Just wondering what some of the feedback was on it.
Well, and John, do you have any experience with agatroban for ECMO?
Not that I can recall, but I can tell you that the cost of these DTIs is pretty earth-shattering.
Yeah, especially in comparison to heparin,
the
right?
cost of them, I remember hearing the number one time, but I don't know, Jeff, do you know what the cost is? It's in the $1,000 range for a single dose, if I'm not mistaken.
Yeah, I don't remember what the cost is. I know it's pretty up there, especially if you're going to use it like on a BBX location, run it for weeks on end or whatever.
Yeah, for sure.
I don't remember what the cost. I don't remember what the cost was. I know Atropine was much cheaper. That's one of the reasons that's the DTI we use in the study.
Okay, well, thank you for calling in, Jeff. I appreciate that, John. So glad you had some experience with that to be able to share with Jeff. And I guess if we're not going to have any other callers, we're going to spin for Jeff for calling in. So.
Well, I'll get called again.
Yeah. Extra call? I think that was. I don't know how that happened. That's not happening today. Yeah, I don't think there should be extra call on here at all. I mean, come on, none of us want that. Right.
I cover my old job call here and there, so I took extra call on my old job.
Gosh, nobody wants extra call. All right, I'm going to go ahead and give this a spin.
That looks funny though. I love it. It's like Wheel of Fortune.
It is. All right. Oh, Jeff has won a Yeti cup. So nice. That's the best thing on here, in my opinion. I mean, I guess $50 Visa card, but I like the Yeti cup. So congratulations, Jeff. Thank you for calling in. Oh, perfect. Perfect. All right. Well, we will be sure.
I have a knockoff Yeti.
You have the knockoff Yeti. Yeah, I have quite a few of those. But you got to be careful with the real Yeti. You can't leave it in the lounge. Somebody's going to walk off with that thing for sure. So.
Yeah, I think my youngest daughter might walk off with it. My 19-year-old.
Yeah, right, for sure. Yeah, my 21-year-old for sure has several Yetis. I have 0 Yetis. So, all right. Well, thank you for calling in. And John, do you have any closing comments for us?
Well, I would say that my first experience with a Yeti cup was one night I had a full drink in there with a ton of ice, no lid on it, watching TV. Oh, it's time to go to bed. And went to bed, came back, later that next day in the morning, and the drink was more frozen than it was when I left the night before. And it had the lid off of it. So those things are amazing.
It is pretty amazing. My first experience with the Yeti anything, someone had, a friend of mine had purchased a Yeti cooler, which if you've never priced those, they're up there too. But he, I guess, had it for recreational purposes, but then ended up bringing it with him when his young daughter had to be hospitalized for a very long time, and they used it as a refrigerator while they were staying in the hospital room with their young toddler, and it worked just like a refrigerator. They just had to get ice, every like 5 days or something crazy like that. So they're pretty incredible. I guess they're maybe worth the price. All right, well, we'll just go ahead and close out here. I want to tell you about our next program. Our next program is going to be Wednesday, May 5th. It'll be our early morning program. It'll be starting at 6:45 and ending at 10. The segments that we will have will be Vanderbilt University Medical Center Faculty Forum, and I believe Dr. Hoffman will be talking about VADS. And then we'll have Tammy Sparacino Journal Club, and the article that will be reviewed will be Ecmo COVID-19 is the membrane a fail-safe to cross-contamination. That should be very interesting. And then John's Knowledge Nuggets will be over surfactants. So please join us on Wednesday, May the 5th at 6:45. And we will look to see you then. Thanks for tuning in, everyone. Have a great evening.
Great job, Tammy. Good seeing you again.
Thanks, John. Thank you, Jeff. Bye-bye.